Hi, we picked sepsis as our topic for our project. Our group members are Erin, Margot, Wallis, Rebecca, Owens, and myself, Chandni, Ranani. So sepsis is a major healthcare problem that has shown to affect millions of people, resulting in high mortality rates. It's going to continue to rise in the next decade. It's a culmination of various clinical conditions caused by the body's inflammatory response. Severe sepsis is a condition wherein sepsis occurs in addition to organ failure and dysfunction. Sepsis can progress to severe sepsis and then septic shock in only 24 hours. Patients require immediate action in order to avoid rapid deterioration. Sepsis resuscitation bundles are groups of interventions that should be initiated together to have better patient outcomes than if the intervention was done alone. Of these interventions, fluid resuscitation is the one that is the most controversial. Some healthcare professionals argue that if you take aggressive fluid resuscitation in patients with medical conditions that contraindicate the use of administering fluids, that it can cause worsening conditions. So others argue that fluid administration is better because you're avoiding the organ failure and the organ dysfunction. So it's better to avoid that than to worsen a condition and then be able to reverse that by extracting the fluids. So we had the opportunity to be able to attend a sepsis conference conducted by Dr. Rivers at Piedmont Hospital, and this further piqued our interest into sepsis management, but more specifically, the controversial use of fluid resuscitation. The following is our PICO question. In patients with sepsis, which implies an emergency department ICU setting, does fluid resuscitation in early stages during their hospital stay identify persons with reduced mortality in comparison to those without fluid resuscitation?
Okay, to summarize what Chandni just spoke about, our P stands for the patients with sepsis, I stands for the intervention, being fluid resuscitation. C, we're comparing it with patients who do not receive fluid resuscitation. O, our outcome is mortality. T stands for the length of time in the hospital. And S stands for the setting, which is hospital setting, being in an ICU or in the emergent department. We began our project by looking for databases that pertain to the field of nursing. These included EBSCO, PubMed, and OVID. Based on our PICO question, the term sepsis was the first term we included in our search box. However, we quickly found out that there were over thousands of articles related to sepsis. Specifically, simply typing in sepsis in EBSCO resulted in 15,000 articles. So we decided to include our intervention in our search process. We tried different terms such as fluid resuscitation, early management, and just simply fluids, and our results began to narrow. Another important part of the research process was finding articles that were current. By including a filter that were based on articles from 2005 to 2015, we were confident that the ones that we would be reading through would be up to date. Another important factor we included was peer review. We knew that this filter would provide us with higher quality articles. And finally, we set the filter to include only articles that were in English for obviously our own purposes, and also we were interested in finding studies that were conducted here in the United States.
Our findings table included a summary of the following articles. Fluid resuscitation in sepsis. This article sought to determine whether or not there is an advantage to using crystalloids or colloid fluids for resuscitation in patients with sepsis. This article is based on a systematic review with meta-analysis and randomized trials, sampling 14 different studies and looking at a total of 18,916 patients from critical care units. The variables used in the study included mortality and crystalloid fluids versus colloid fluids used to treat the patients. The objective of the study was to examine the effect of various resuscitative fluids on mortality in these patients, assuming there was a difference in outcomes between the patients who received crystalloid versus patients who received colloid fluids. It was found that using balanced crystalloids or albumin compared with other fluids resulted in a reduced mortality rate with these patients. Article 2 was entitled Effects of Fluid Resuscitation with Synthetic Colloids or Crystalloids Alone on Shock Reversal, Fluid Balance, and Patient Outcomes with Severe Sepsis. This article sought to determine whether or not synthetic colloids or crystalloids alone reversed shock and fluid balance in patients diagnosed with sepsis. This article focused on time periods in which the fluids were given, as well as types and amounts of the fluids. The main objective was to assess shock reversal and the required fluid volumes in patients with septic shock. This study used a prospective before and after design, which compared 3 different treatment periods and included patients who fulfilled the criteria for severe sepsis or septic shock on the day of admission in a 50-bed, single-center intensive care unit. Results indicated that patients with abnormal serum lactate levels at the time of admission attained normal values just as quickly despite the choice of fluid used. Article 3 was association between the choice of IV crystalloid and in-hospital mortality among critically ill patients with sepsis. This article examined the association between the choice of crystalloids and in-hospital mortality during the resuscitation of critically ill adults with sepsis. Researchers used a retrospective cohort study to compare patients' outcome after receiving crystalloids during the initial resuscitation period. The researchers found that the receipt of balanced fluids during initial resuscitation was associated with a lower risk of in-hospital mortality, and patients receiving the greatest proportions of balanced fluids had the lowest risk of in-hospital mortality. Article 4 was entitled Fluid Resuscitation in Sepsis, Re-examining the Paradigm. This article, based on a systematic review, examines the type, timing, and quantity of fluid to be used in fluid resuscitation. The article pointed out that fluid resuscitation is one of the cornerstones of management. Results indicated that each fluid should be considered a drug with specific pharmacokinetic, pharmacodynamic, and adverse effect profiles, which can be carefully matched to the patient. Whichever fluid is chosen, resuscitation should be titrated to evidence-based targets, combining clinical assessment such as signs of tissue perfusion with dynamic hemodynamic monitoring. Article 5 on our findings table, Early Recognition of Management of Sepsis in Adults, the First 6 Hours. This article shows the importance of early goal-directed therapy completed within the first 6 hours of sepsis recognition and its significant decreases on in-hospital mortality. Initial management includes respiratory stabilization, followed by aggressive fluid resuscitation. The article further explains that fluid resuscitation is the initial treatment for hypotension in patients with septic shock. It explains that the highest priority in early sepsis is establishing vascular access and initiating fluid resuscitation. In regards to fluid resuscitation, hypovolemia, myocardial depression, and hypoperfusion result in hypotension, which is the most important event leading to increased morbidity and mortality in patients with sepsis. Delaying fluid resuscitation can worsen tissue hypoxia, leading to multiple organ dysfunction. Article 6 of our findings table was titled, Increased Fluid Administration in the First 3 Hours of Sepsis Resuscitation is Associated with Reduced Mortality, a retrospective cohort study. This article questioned the best time for fluid resuscitation with septic patients. Researchers used a retrospective cohort study to compare patients' outcomes with implementation of fluids within the first 3 hours of sepsis onset and implementation of fluids within 6 hours of sepsis onset. The findings of the study show a higher survival rate with 3-hour implementation versus the 6-hour implementation. It should be noted that there is increasing evidence that late fluid resuscitation results in harmful effects, such as increased mortality and worsening lung and renal function. The final article on our findings table was Fluid Balance in Sepsis and Septic Shock as a Determining Factor of Mortality. This article focused on whether or not fluid balance has a determinate impact on mortality in patients with sepsis and septic shock. Researchers used a prospective and observational study on an inception cohort to collect data. This study determined that fluid administration at the onset of severe sepsis or septic shock is the first line of hemodynamic treatment. Also found was that an accumulative positive fluid balance, such as intake greater than output, in the first 48, 72, and 96 hours is associated with higher mortality in these critically ill patients.
So the article we chose to appraise was entitled The Effect of Quantitative Resuscitation Strategy on Mortality in Patients with Sepsis, a Meta-Analysis. This article was an integrative research review, and to begin, there should be a clear objective statement which was found in the abstract of this article. The purpose of this article was to measure the treatment effect of quantitative resuscitation on mortality from sepsis, and the researchers hypothesized that results from early clinical trials may be combined to provide a more accurate conclusion regarding the effect of quantitative resuscitation. Next, it is important to provide a detailed description of the research process. This article included specific databases such as the Cochrane Library and Medline, and they included specific search terms as well, such as sepsis, septic shock, severe sepsis, critical care, hemodynamics, resuscitation, oxygen, goal-oriented therapy, goal-directed resuscitation, and early goal-directed therapy and clinical trial. Inclusion criteria of this study was also defined in this article. Their inclusion criteria consisted of randomized controlled trials of adults greater than 17 years of age, and also these patients had to have a diagnosis of sepsis and treated in an experimental study using a defined intervention consisting of cardiovascular resuscitation and a control group that received standard care therapy. The exclusion criteria of this article consisted of reviews, correspondence, editorials, and non-human studies.
A table describing the population, methods, and findings of individual studies should be included in an integrative research review. I have pulled up here the specific table that was provided in our article. Finally, as it relates to credibility, conclusions should include the evidence that led to it. And now Erin will discuss that with you.
Our article's clinical significance showed that the summary odds demonstrated a significant reduction in mortality among subjects receiving the quantitative resuscitation. The odds ratio was 0.64, and the confidence interval was 95%. The overall mortality rate in the early quantitative resuscitation group was 39%. Patients randomized to receive early quantitative resuscitation compared with standard resuscitation had significantly lower mortality rate, The odds ratio for that was 0.50 with a 95% confidence interval. Late fluid resuscitation showed no impact on improving mortality rates.
Controlled trials and independent reviews of articles. The study was conducted well, providing very compelling results. The articles conclude stating that an early quantitative resuscitation strategy for patients with sepsis provides a significant decrease in mortality. The article followed a research protocol from the Cochrane Handbook for Systematic Reviews of Interventions. The criteria for the review included adults, a diagnosis of sepsis, and being treated in an experimental study with a clearly defined intervention consisting of fluid resuscitation protocol. Appraisal of the articles used accepted diagnostic criteria and internal validity assessment. The findings are credible due to a large difference in mortality rates. For example, 39% mortality rate for early quantitative resuscitation versus a 64% mortality rate for late quantitative resuscitations in sepsis. The findings are clinically significant due to the importance of the health benefits that result from an early quantitative resuscitation strategy. Patients are at higher risk for mortality if aggressive fluid resuscitation measures aren't enforced and applied early. The benefits outweigh the risk of organ failure and organ dysfunction significantly.
Here we have an acronym that could easily be placed on a hospital badge for employees to look at, just to have a quick overview of the signs and symptoms of sepsis. So the first S stands for shivering, very cold, and a fever. E stands for extreme pain or discomfort. P stands for pale or discolored skin. The next S stands for sleepy or difficult to arouse. I, the patient might state that they feel like they're going to die. And the last S is that the patient may feel short of breath.
Hey Margot, how's it going today in the ICU?
Well, actually, I'm just preparing some fluids for one of my patients. He's septic right now.
How'd you know he was septic?
Well, thankfully, I got this great badge that explains all the warning signs of sepsis.
Nifty.
And now we'll discuss our evidence-based practice project proposal. Because ICU nurses commonly encounter septic situations, we feel it would be wise to start with approaching ICU nurse educators and nurses in order to form a system-wide specialized sepsis committee. This committee should also be composed of multidisciplinary personnel such as doctors, physician assistants, patient care coordinators, pharmacists, clinical nurse specialists, and of course, nurses. The committee should meet monthly to discuss specific septic patient cases and work together to determine how care can be better provided. We have learned the importance of interprofessional communication and believe that providing a format such as a committee would provide a safe environment for feedback and improvement regarding sepsis. Dissemination of newly formed sepsis protocols can be approached in several ways. The CDC provides an excellent acronym for recognizing the signs and symptoms of sepsis. Creating a card with the sepsis acronym that attaches to the healthcare worker's badge could be a helpful tool that is easily accessible, as you saw in Chandni and Margot's skit. Also, a unit in service provided by the newly formed sepsis committee would be helpful in initially alerting nurses to this issue. As Chandni mentioned earlier, our group was able to attend a hospital in-service on sepsis. This really sparked our initial interest in the topic. Including a review of sepsis protocols during morning unit huddles can also increase awareness. Finally, we would like to propose including a pop-up warning in the electronic medical record system. This would alert nurses and staff of patients with septic symptoms. For example, an input of a combination of fever greater than 101 and respirations higher than 20 would result in a warning box alerting the nurse.
Our research has shown that the use of fluid resuscitation has led to a reduction in mortality rates in patients. The main underlying principle in the use of fluid resuscitation is tissue perfusion. Early fluid resuscitation treatments reduce the risk of worsening tissue hypoxia, thereby reducing the risk of organ dysfunction as well.
Sepsis places patients at a higher risk of mortality if aggressive fluid resuscitation measures aren't enforced or applied early. Sepsis can be deadly. It kills more than 258,000 Americans each year and leaves thousands of survivors with life-changing after effects. According to the CDC, there are over 1 million cases of sepsis each year, and it is the 9th leading cause of disease-related death.
Nurses play a key role in the recognition and treatment of sepsis because they are the first to recognize symptoms due to proximity and the time spent with the patient. Some of the early signs of sepsis include an elevated heart rate, fever, high white blood cell count, and elevated respiratory rate.
In conclusion, many of our articles focused on the use of fluids in the treatment of sepsis. However, a common theme throughout all of our articles focuses on the early recognition of sepsis. It is for this reason that our project proposal focuses on identifying sepsis symptoms early.
As future RNs, we hope that this project will help you keep sepsis in mind and you will remember the important role you play in this life-threatening disease process.